First and foremost, I want to welcome all of you to the 19th Annual Hewitt Healthcare Lecture. I'm Jim Stergios, Executive Director of Pioneer Institute. Thanks for being here tonight. I think it's a really important conversation we have for tonight for Massachusetts, because we're one of the world's greatest life sciences clusters, but also for the nation. I also want to recognize their attendees online, and this event will be recorded. So behave well, please, and we'll distribute it. So let me first start by saying thank you to the Hewitt family. Really appreciate them. Round of applause for them. They've long been committed to the American healthcare system and advancing it. That story begins with Colby Hewitt Jr., who was our longest serving chair. Chuck and Teak, Chuck is a board member now, have kept that tradition going. And we're really grateful for that, Chuck. Thank you. We're also honored to have other members of the Hewitt family here, Colby Hewitt IV, John and Josie Marston. Colby will be providing some closing remarks at the end. Thank you for doing that, Colby. Appreciate it. My thanks also to Bruce Johnstone. Where are you, Bruce? Thank you very much for sponsoring tonight's event. And I just want to recognize WilmerHale. They've been a great partner to Pioneer Institute as we've started our law center. And they're an important firm here. They're important to us, and we really appreciate the space this evening. For the friends who have not been here before, I just want to share a little bit on Pioneer. We're founded 37 years ago. We work in 4 core areas of what we believe drives human potential: education, K-12, medical innovation, that's what we're here to talk about tonight, economic opportunity, and American citizenship. Pioneer mainly focuses on state policy solutions, though in the policy area we're talking about tonight, Bill and Robert Popovian, who will introduce in a little bit, they work a lot in DC as well. It's an important center of where the action's happening. In each of our 4 policy priorities, we've assembled really great teams. Bill, thank you for your leadership of the team. Robert, thank you for your leadership of the team. Really appreciate that. They are everywhere. I think you told me this, Bill, correct me if I'm wrong, but I think the last 18 months you've been in 19 different states. That's amazing energy, and thank you for bringing ideas all across the country, so thank you. Early in the Hewitt Healthcare Lecture's history, we talked a lot about something called Romney Care, essentially experimentation with exchanges, and those were heady days in Massachusetts. We talked a lot about bringing markets to the power of markets to the healthcare sector. With the arrival of the Affordable Care Act, Obamacare, in 2010, we started talking about implementation of that, what was right about it, what was not working about it. And we've talked a lot about transparency of pricing and the quality outcomes. Several of our lectures have been on that. Over the past 8 years, we've been laser focused on the life sciences. Now that we've started the Life Sciences Initiative, it's important because it is the one thing that we see out there that's truly transforming the healthcare market. And I say this whenever I talk to people. One of the things as a non-expert I always looked at was how many hospital beds are there? How are people receiving their care? Where are they receiving that care? If you go back to the 1970s, we had about 1.7 million hospital beds. We've got about 850,000 of them. And I know some of that's other market stuff, but a great deal of that is the fact that we have so much outpatient care, which is undergirded by the life sciences sector. We're really interested in who pays for things, where the care happens, and how it's delivered. It's important to us, but the reason why we care about those things is we want to protect innovation in the sector, and we want to make sure that people get access to therapies. We're really proud of the incredible speakers we've had over the years, and we're really honored to have Tomas Philipson with us this evening of the University of Chicago. He's continuing this important annual tradition. So thank you for being with us, Dr. Philipson. A quick preview. Bill Smith is going to come up. He's going to demonstrate a new web tool that we've designed to track the impact of the Inflation Reduction Act's provisions, price control provisions. It's a law that was passed in 2022, already well underway in terms of implementation. Following that, Robert Popovian in these nice semi-comfy chairs will sit with Dr. Philipson. I think those are a little bit short for you, Dr. Philipson. It's going to be kind of tough for you. Stick your legs out. It's okay. They'll be talking about how insurance companies and pharmacy benefits managers in real life are responding to the IRA's price control provisions and what their decisions mean for patients and for the future of drug innovation in America. Colby Hewitt, again, will be closing. Before I ask Bill Smith to come to the podium, I'd like to express thanks to John Guerra. Thanks very much for working on the event tonight. Appreciate that. And to all of you, thank you for being here. Really appreciate. We look forward to staying engaged with you on these issues. Bill?
Jim, thank you for the kind introduction. Drug price controls is something we're going to talk about tonight. I've been reading polls about drug price controls probably for 4 decades. And the thing that strikes you about those polls is that drug price controls poll very high if you just ask, should the government impose price controls on drugs? The results are much more mixed if you say, should the government impose price controls if it reduces new drug development? And so the polling is very mixed, and sometimes the pollsters play games to get a good result. Dr. Philipson is an expert on how drug development might be impacted by price controls. So I'm going to leave that segment to him. But we wanted to look at how price controls might affect patient costs, because everyone inside the Beltway assumed when the government pushes the prices down, drugs are going to be much more affordable for patients. And Robert and I understand how pharma markets work, and it works on a rebate system. And when you push prices down, you don't necessarily get more affordable drugs. You sometimes get more expensive drugs for patients themselves, out-of-pocket costs. And the reason for that is that the pharma markets work on a rebate system. So the pharmacy benefit managers, the PBMs who represent health plans and negotiate with drug makers, they approach the drug maker and they say, nice drug you got there. Be a shame if something happened to it. And so the drug makers come across and pay rebates, which is protection money, so that the drug gets on a good formulary with low out-of-pocket costs. The doctor's paperwork is minimal. When a patient gets a prescription, it sails through and the patient doesn't pay much out of pocket. So given that, Robert and I were thinking, well, if the government pushes down these prices on these price-controlled drugs, the rebates are going to be diminished. And if the rebates are diminished, the protection money is diminished, what's going to happen? Are patients going to end up paying more? And so we wanted to test this theory, so we went out and developed a tool to test it. And the results are pretty stark. We bought out-of-pocket data for the 4 largest pharmacy benefit managers that manage the pharmacy benefit for Medicare Part D. That's the seniors Part D benefit, drug benefit. Caremark, Express Scripts, Humana, and Optum RX, which is a United Healthcare PBM. And what we discovered is that since the price controls have been enacted, the out-of-pocket costs for patients have risen 32% in 1 year. If you look at all drugs on the right-hand side, from Q1 2024, it rose from about $74 on average for a price-controlled drug to $98, about a $24 increase. And that's kind of what we expected, because when you're not paying the protection money, the PBMs say, okay, we got to make up the revenue somewhere, so we're going to just charge the patients more. And that's what we discovered happened. So the results of let me just read some of the high-level results that we discovered. The average out-of-pocket costs increased for the price-controlled medicines by 32%. On average, they increased $24 from $74 to $98, and cost increases ranged from $10.56 to $316. So it's clear what's going on. The PBMs are trying to make up for lost revenue in the system. Here's the other thing we're tracking, and we didn't get as powerful a trend with this data, but we're going to track the paperwork requirements that PBMs impose on patients and doctors. So QL is quantity limits, PA is prior authorizations. These are the paperwork requirements that the PBMs make doctors and patients go through in order to get their medicines. And our sense is if they really want to move patients off these medicines, we're going to start to see a trend with these particular utilization management techniques, as they're called. So that's it. I'm done. I'm going to turn it over to the great experts here.
And I've known Tomas for a long time. So he's a professor of economics at the University of Chicago. He's also the former chair of the Council of Economic Advisors at the White House in the last Trump administration. So he's very well versed on all of these things. So I'm going to have him start talking about IRA and the impact of IRA potentially that he's been looking at. And then we're going to get into, I'm going to ask some questions, but then we want the audience to also ask questions, because this is an important issue, because at the end of the day, and Tomas is the best person to talk about it, is that the future of innovation is really at the crossroads here. So Tomas.
Yeah, thanks for having me. First of all, appreciate it. We'll get into the IRA in detail in the discussion here. So I'm going to start with kind of two myths that I believe people have strong beliefs on that might potentially be the wrong beliefs. The first is that drugs, raises prices are very costly. And the way an economist would think about that, when we think about innovation, we think about innovations as price reductions, always as price reductions. So if you think of something like an Apple iPhone, before it was innovated, no one was using it. That's the same thing as an Apple iPhone being too expensive for anyone to be able to afford it. So if you think at that price at which no one would buy it, innovation is essentially interpreted as just bringing down prices from that price. So for healthcare or drugs in particular, when we innovate, we always lower prices. In particular, the price of health, meaning, so let's take HIV or breast cancer or whatever. A few decades ago, when you got those conditions, you couldn't buy a longer life anywhere on the planet. But today you can buy a longer life through innovation that basically lowered the price of better health. So it was prohibitively expensive to live longer, in the 50s from if you got breast cancer many times, and for hepatitis C, which is sort of miracle innovation, we now have a cure essentially, which 10 years ago many people died of that condition. So innovation always lowers prices, the price of health, even if it costs $1 million a pill or whatever. If you have a drug, it's always cheaper than what it was before to buy better health. So that's one issue. It also often, not always, reduces healthcare spending because it many times reduces other forms of healthcare spending. So if you have antidepressants, you don't have as many shrinks. If you have statins, you don't have as many heart attacks that has operations in the hospital, etc. So many times, even for initially expensive innovations, which is why we have the patent system to innovate, to get innovators to basically get compensated for undertaking large R&D costs. Even when you have those initially expensive innovations, you many times have that total cost go down with drug innovation, even though drug spending might go up with such innovation. So there's a difference between the total healthcare cost versus the innovation. The spending on the innovation obviously goes up, but the question is if it goes up more or less than other forms of healthcare gets reduced. Now, once it goes off patent and generics come in, it's very, on average, that will always almost on average reduce total healthcare spending, because if you look at the data, roughly what CBO uses as these cost offsets on other forms of healthcare, they say about 20% cost offset for every dollar spent, we save 20 cents on other forms of healthcare. Every dollar spent on drugs, we save 20% of other forms of healthcare. Not fully offsetting if initially, but if generics come down, and they come down roughly to 20% of the prices of the brand drugs once patent expires. That means roughly that it's a wash on average for each new drug innovation once it comes off patent in terms of affecting total healthcare spending. So that's the first myth, basically, that drugs many times raises prices. The second myth, which is more recent work we're doing, has to do with US. Everyone believes US have higher cost of prescription drugs than other countries. That turns out to not be true many times for many countries. So what I mean by that, that sounds crazy when I say that. The reason is about 70% of prescriptions, or 7%, sorry, about 7% of prescriptions are brand name drugs. 93% of prescriptions are generic drugs. Generic drugs are cheaper in the US than other countries. Brand name drugs, which you hear about all the time, are more expensive in the US. But generics are also far more used in the US. Like I said, 93% here. If you go to Europe, many times that number is about 80%. So they have a higher market share of brand name drugs that are more expensive than the generics in that country. So we have a higher penetration of cheaper drugs, generics, and we have lower prices of those cheaper drugs, generics, which many times offsets the fact that we have a smaller share of our prescriptions being brand with higher prices than those other countries, essentially. So I think that's very important, because when you get sick, you go and write a prescription. And on average, many times in the US, that prescription is cheaper than the countries we're talking about having cheaper drugs than us. They do have cheaper brand name drugs, but we have much more fierce generic competition, and therefore they have protected generic industries sometimes, and therefore it's misleading to say that the US have higher prices of prescriptions than other countries many times. Sometimes it's true, but not always. Depends on the country. So I'll start with those two, and then we'll get into some IRA discussions.
So Tomas, thank you so much. IRA, in my opinion, and I've been over 25 years in this industry, is probably the most consequential one of the legislative effects that is going to have on the future of innovation. The Congressional Budget Office determined that it's going to impact fewer drugs coming to the market, without a doubt. So that question has been answered. But I also think, and I know I've read some of the work that you've done, is that number is way below what economists such as yourself are anticipating, that the CBO is saying, 15 drugs over 10 years. And I want to hear from you what your estimate is, and what type of drugs are we talking about? Are we talking about the fifth hypertensive drug, or the newer innovations like in rare disease or ultra rare disease drugs?
Yeah, so CBO came out with an estimate, which most people like me were scratching their heads. And the reason we scratch our heads, which is generic for any government institution, not just CBO, is that when they come out with results many times, they show you the results, they don't show you the analysis. So no one has a clue how they got this number. And the reason they don't show the analysis is because they don't want to look stupid, or they don't want to look politically biased. One of the two, essentially. So many times, it's not just CBO. I mean, commerce has the exact same problem. You just come out with these results, and people are like, how did you get there? And we don't really talk about it. So I have actually proposed that CBO comes out with a replicability standard, which is in academic research, you should be able to replicate someone else's analysis and see, oh, if I do it that way, do I get the same result? And that's what all journal publications aim to do. You should be able to replicate it and actually come up with the same result. That's not true at CBO. And I actually proposed, I was actually nominated to be CBO director, and that was hated when I brought that up. It's selected by the two budget chairs, the two ranking members on the budget committees, and the speaker get the to break the tie between the two parties essentially, and Nancy Pelosi was the speaker, so I was out. So anyways, I was talking a lot about them that I wanted replicability at CBO, which was not popular at CBO. With some lawmakers, it was very popular, but certainly not popular at CBO. So anyways, they came out with this number where no one knew where it came from, and then we did a very simple analysis. We took their revenue effect. They said revenues will go down about 12% or something like that. Then there's a large literature that shows how much R&D responds to revenues. So the more you earn in the market, the more you're going to try to have R&D to get that earning, etc. So there's a relationship between what revenues are when you sell something and how much people spend to try to get it. If you take those data essentially and just take the literature out there, you get estimates about 125, 135 drugs going to be lost during the same period instead of 15 essentially. So tenfold difference essentially. We turned on, then we went to the actual behavior after the act passed. And then we went to the earnings calls of public companies and which are important because if you lie during those, you can go to jail. If you lie to your investors, you know, there's SEC rules of what you can and cannot say in earnings calls to your investors. But they were talking about much more than 125 in those earnings calls being dropped because of the IRA coming in essentially. So we actually underestimated, it looks like, of the reduction in R&D that's going to be taking place when they talk about the pipeline. When Pfizer and Eli Lilly, et cetera, talk about the pipeline that's getting cut because of IRA, essentially, and you look at how many drugs that involves, essentially. That prompted CBO then to come out with a request for information on how to evaluate the impact of price controls on lost drugs or innovation, essentially. So that's where we are now. At least they kind of learned a lesson. I don't know if it's going to be adjusted or not, but that was actually a huge debate during IRA because everyone, you know, CBO, I think was biased. They wanted to say IRA is good and therefore you don't lose a lot of drugs. And that kind of came across and no one knew how they got there essentially. But if you look at the actual data afterwards, it looks like even we underestimated the effect.
Yeah. But Tomas, let's go to something you mentioned, the earnings calls, because, you know, Bill and I for many years worked at Pfizer, and one of the companies like Pfizer has in their earnings calls said they're shifting their research and development budget away from small molecules to large molecules. Can you talk about what IRA did with regards to those incentives and what are the consequences of those? Because frankly, large molecules not only cost more, but there's an administration cost issue that nobody seems to notice. Pfizer, just to let you guys know, their oncology portfolio was 90% small molecule, 10% large molecule, and it went to 60% large, 40% small because of the IRA. So
yeah, I think the IRA basically gives you a lot more time before the price controls come in if you're a large molecule. For those of you who are not in life sciences, large molecules you can think about as injectables, like chemotherapy. Small molecules you can think of as a pill you take or you buy from the pharmacy. Large molecules you often buy from the doctors only, as opposed to the pharmacy. So large molecules got 13 years until the price controls come in for those drugs that are actually facing price controls. Small molecule got 9 years. That's been referred to as a pill penalty because the small molecules are getting hammered sooner than the large molecule. In the new executive order that came out a week ago from the administration, they are actually going to try to address that. But the issue is that the companies now are much more interested in investing in R&D of large molecules, obviously. They're going to have a longer stream of profits on those investments, and then they will have on small molecules. There's a couple of problems with that. One is patients prefer pills over injections, presumably. Most people do. So it's, you know, not something that patients like, particularly to have injectables. Second is that basically it's much more costly to administrate with a doctor than through a pharmacy, essentially. So you're pushing innovations into more costly drugs, essentially, And they usually cost a lot more biologics. They're much more harder to produce, etc. Now, there's a peculiar feature in the US, which is Medicare Part B, which is the doctor program when you have drug administration administered by a clinic. Think of chemotherapy or something like that. Part B, or doctors, is a very unique market setting because it turns out that this program makes consumers like higher prices. Very few markets, consumers like higher prices. The reason doctors like higher drug prices is because they get paid a percentage of the drug cost to administrate the drug. So if you administer a $100 drug, you get paid a certain amount. If you administer a $1,000 drug, you get paid more. So why not? You want to have the most expensive drug that you administrate every day.
Mm-hmm.
So that's a consumer market which likes higher prices. And as always, consumers always get what they want. So you have high prices in Part B, essentially. That's where all the skyrocket prices of oncology drugs sits in Part B, essentially. So it's a very perverse system in some sense for getting lower healthcare costs when the person administrating or basically buying the drug, if you want, prefers a high price. It's very unusual for markets to operate that way. But it shouldn't be a mystery, therefore, why we have such high prices in that market.
Yeah. So you brought something interesting up, which is, individual products that we're talking about. And one of the things that it's very obvious is that the way they chose these products with regards to which ones are going to be price controlled, and it's not even negotiation, right? It's a price control, it's a price setting by the government. Can you talk a little bit about how they were chosen and what the consequences are? Because some of those drugs in the next phase that are coming on are really the innovative drugs like we're listening to every day, which is Ozempic and those things.
Yeah. So the way that the act was set up, which is, I think we want to have a change in the future, at least I do, is that the way they select the drugs to be negotiated is on the spending level on the drug. So you have a high spending drug and you have a low spending drug. We're going to go after the high spending drug. That sounds good until you realize that spending is due to two things: price times volume. And the drugs that are qualifying are mainly high volume drugs as opposed to high price drugs. So a lot of patients are taking Ozempic. Doesn't matter what Ozempic price would be, it would qualify no matter what, even if it was low priced. Ozempic would qualify because so many people are taking it, so it's a high spending drug, essentially. So this is a perverse system, because if you help a lot of patients with a low price drug, even when you lower your price, you might actually increase spending on it because the volume might go up more than the price goes down, essentially. But if you help a lot of patients, the government's going to come after you here, which is kind of perverse, okay? And 60% of the initial 10 drugs had this feature, which is that the reason they qualify is because a lot of people, there was a big disease and a lot of patients take the drug, as opposed to that it was highly priced. And that's very, very perverse, because you want exactly the opposite. You want to basically have free market pricing when you help a lot of people, and then maybe not when you don't. And that's why we have orphan drug acts, to stimulate innovation on small disease drugs, essentially less than 200,000. We want to have we might want to have the government stimulate those small markets, but we definitely don't want to have the government come in on big high volume markets and come in with price controls.
Because it affects a lot of patients. And we saw the one example that Bill put up is the Eliquis issue, right? It is taken by a lot of people in this country, and the consequences can be affecting multiple people.
Yeah, I mean, if you look at Medicare, about a third of Medicare spending are tied to diabetics. We would love something for diabetics, and Ozempic and these guys are partly on the way. But we don't want to penalize the people who are going to cure diabetics, because it's a high volume disease, essentially.
Or Alzheimer's or things like that, which is a lot of demand. So one of the things that you talked about was price control. So one of the areas that the government has talked about is that even though they've gone through this first set of price setting and they're going through the second set, there's supposed to be a center that's created within CMS. Can you talk a little bit about that? What are the criteria are they using? Are these qualified? I mean, they've sort of, are they using people that actually understand these dynamics that you're discussing right now?
I'm not going to comment on that, but I'll be polite. No, but one of the issues with this center is they are allocated $3 billion over 10 years, which is a massive amount of money for people sitting around thinking about what prices should be. It's about 10 times the money that it takes in the private sector. There's an organization that people in the life science know about. This organization is called ICER. They basically evaluate the cost effectiveness, how much benefit there is for a drug relative to the cost of the drug. They do it at the 10th of a cost, their evaluations, compared to what each price determination of this group would be. What that is a red flag for is that there's going to be mission creep out of this center. They don't know how to spend the money on just sitting around thinking about what prices should be. So there's going to be other things that they're doing. The more important thing is that by law, Medicare does not allow for so-called cost effectiveness analysis to determine prices, meaning the type of structure that the UK has. The UK has a very, very strict structure where you measure health benefits. They're called quality adjusted life years, but it doesn't really matter what it's called. But you measure the health benefit of a drug. You measure the cost. If the cost is too high relative to the health outcomes, then you would have to lower your price to qualify, etc., for the National Health Service in the UK. That is not allowed in the US, but it's being brought into price setting in the US through the back door, because where do these people at the CMS center get their price that they think is appropriate for this drug? They're going to have to control the price and say what's an appropriate price. Well, they go talk to ICER, the private organization that does cost effectiveness analysis, essentially. And ICER says, oh yeah, this was a good recommendation on price by CMS. It is consistent with our analysis of the cost effectiveness of this drug. So they're basically bypassing this law on Medicare by basically taking the private sector evaluation of these drugs and then coming in to CMS that way. I think it's going to be a very contentious thing. The problem with both NICE and ICER is that when they value health generated by medical innovation, they value it at about a 10th of the value of health that the government says should be the value of health when the government does something. So if you go to EPA, if you go to a bunch of agencies across the government, they all have a number of what it's worth to save 1 year of life, a life year, okay? Because they have to. If EPA reduces global warming and they save, hundreds of millions of life years because people live longer or whatever, they have to have a number to do a cost benefit analysis of their regulations that then goes to OMB and gets rubber stamped that says, yes, this passes the cost benefit test. So all departments have this number. It's in the 400,000 or 500,000 per life year. That is telling you that when the government generates health, it's worth 400,000 or 500,000. When the pharmaceutical companies generate a drug that improves health, it's worth about 40,000 in the UK. 40,000 in the UK has been the same number for the last 25 years. We're not adjusting for inflation here. This is the same nominal number for the last 25 years. And it's about a 10th, roughly, of what the scientific literature, which is why the departments have that number across the US government, says what the number should be. Has nothing to do with the value of health. Has everything to do with suppressing budget spending on healthcare, essentially. So it's kind of camouflaged as a scientific way of determining drug prices, which is completely untrue because they're undervaluing it by tenfold, essentially.
Which is the 40,000. I was in grad school when that 40,000 I
got
was
you.
using, which was a long time ago. There was no Schaefer Center yet at USC where I went to school. So my last question, and then we're going to open up to the audience. One of the things that you started talking about was the generic market in the US. You know, without a doubt. I mean, even ASPE admits that for every dollar that developed countries spend on generics, we spend 60 cents. We spend significantly less on generics in the United States. We have a very competitive marketplace. And the impact is, it's not just about the IRA and the brand name drugs, but you had very interesting comments about what the future would look like for generics coming into the market, because we want to keep that competitiveness, right? Because 93% of the prescriptions are generics. And even though the prices have lowered, the value of these medicines go on for perpetuity. The value doesn't change of a Lipitor generic. So can you comment on what the future will look like, in your opinion, with regards to generic introductions and specifically with biosimilar introductions?
Well, it's tricky now, because if you're sitting in your generic or biosimilar, you want to come in a given market when the patent expires for that particular drug. That's a pretty certain thing. You have the patent office, you know the patent, how long it's going to be, et cetera, and you invest accordingly. It takes a year to go to market with these things in terms of coming online to compete at that date where the actual patent expires. With the IRA, now it becomes a lot more uncertain, because they don't know exactly which drugs are going to be price controlled that they're targeting. So if you're targeting in a given drug, and then the government comes in and price controls that drug, your investment the last year is worthless, because basically the government is going to bring down the price. And then you coming in and bringing down the price is not worth very much. So the generics are, you know, it's not an either or thing. It's basically a declining price schedule with the number of generics that come in. Usually it's maybe more than 10 or 20 when they're done. But the initial guy earns a lot more than the second guy, that earns a lot more than the third guy coming in, essentially. But those investments are going to be much more uncertain, because it's not clear, because the process is not transparent enough at CMS, which are the targeted drugs or eligible drugs that are going to come up for negotiation, and therefore going to make the generics not obsolete, but less profitable, certainly. Okay. Another problem is that generics are, you know, much better at competing down prices than a government price negotiator is. They don't know the cost of production of the companies. So many times they will potentially set higher prices than the initial generics would, essentially, because the generics know the cost of production. It's a very competitive market. So we think that when they bring down cost to 20% of the initial brand price when the patent expires, we think that reflects the cost of production of these generics, that there's some margin, 5% or whatever it is, on top of that cost of producing the medicines. But that competition essentially drives it down to sort of marginal cost of producing it, which a regulator would not sort of have the same information about. And they also are susceptible to, you know, favoritism or lobbies or whatever have you, to protect a particular drug. So I think, you know, competition is very, very good at bringing down prices. Regulators, many times, not so much.
Agree. So I want to see if anybody has any questions in the audience. Yes, sir.
So this might be a naive question, but is there the sense that there are plausible mechanisms? Well, first of all, is it a reasonable question as to whether there are, you know, some innovations more than others? Is there a mechanism to sort of separate the wheat from the chaff in not hindering the development of sort of drugs that high value drugs, whether it's other, you know, drug development activity that wind up kind of paying for?
I don't know what would be low. I mean, like if a drug sells, I mean, that's the ultimate test of whether it's valuable, in my view. You know, it might not be as much sales for a small disease as a big disease.
Incentive for providers to, you know, cancer drugs. I mean, there are a lot of reasons why.
Well, that's a separate, yeah. That's a separate issue. Yeah, that's a separate issue. Do we design reimbursement better to basically align with value? That's a separate issue. But once you have the, if we agree that that's the way it should be reimbursed, even though some people don't, or if you look at other markets outside injectable or large molecules in clinics, hospitals don't have these perverse incentives, for example. So, in those markets, whatever the innovators come up with and it sells is valuable, presumably, right? Unless you think there's some problem with the reimbursement.
Any other questions? Yes, sir.
Private equity seems to have totally dried up in the biotech development industry. Is that being driven by that? What's the impact of that?
I think, yeah,
Future growth?
very good question. So there's, a lot of countries are hammering down on earnings of earnings or the returns to innovation, essentially. I want there to be as many biotech billionaires as possible. Some people don't like that, but I like it. Because when they generate something, the value they generate, the billions they earn is peanuts relative to the value they generate in terms of the value of health. Health is the most important commodity that we have. Most people understand that if they don't have their health, they don't have a good life. So any estimates that economists come up of what the value of health is dominates everything else. So for example, if you look at GDP growth the last 100 years, roughly, all GDP growth is equal to the value that we extended life so much during the last 100 years, essentially, because people really care about health or living long and living well in terms of that. So coming back to your question, this earnings pressure has basically dried up a lot of R&D, not surprisingly. And the VCs start the process, the Ps, so the private equity guys come in later when they come into phase 3. Phase 1 and phase 2 is mostly venture capital. Phase 3 is mostly private. When the PE firms are in there, they're in phase 3, and then they sell it to the public guys, the Pfizer, the Lilly's, etc., the public companies. We have actually developed a product now which is going to try to solve this problem, which is you need to reduce your cost of development once the earnings pressure is coming down to keep the rate of return the same. The reason it's so costly to develop drugs today is because 90% of them from start to finish fail the FDA process. So you're spending a ton of money on losers, and all the winners, the few winners, have to pay for all the losers. So that's when you see these skyrocket drugs or earnings on a given drugs. People go crazy. Bernie Sanders goes crazy when he sees these earnings on a given drug. Those earnings have to pay for the 90% of drugs that never made it to market. The winners have to pay for the losers, essentially. So if you clamp down on blockbusters that hit the market, you're eliminating a huge amount of R&D because you're not going to be able to make up it. If you don't have blockbusters, you're not going to have all the failures that you can finance, essentially, with blockbusters. We developed the product for Lloyd's of London, which is now going to insure companies for failure of a clinical trial. So if you invest $100 million in the trial, the drug does not work, Lloyd's of London sends you a $100 million check. So basically, so the underwriting is being done by a company called GATC Health, which is a new company in California with Human Genome Project guys and eBay guys that have merged into one company. They're the leading AI company to predict whether a given molecule is going to have activity in a given target. They have done an independent study. They're the only company, for disclosure, I'm on the board of this company. They're the only company that has a third-party evaluation of their platform. UC Irvine Chemistry Department went in and sent them 10,000 molecules blindly. They were correct 85% of the time. Compare that to investors, where many times they fail. It's 90% failure from start to finish, but on a given drug class in a given phase 1, 2, 3, is 50% failure rates many times. That's what's going to hold premiums down on this insurance, because you're not going to qualify unless GATC Health says your molecule is going to qualify and it's likely to have a high activity level in the target. So the premiums are not going to reflect the average failure rates of trials. They're going to be a much lower failure rate than the average trial, and therefore a lower premium to cover that lower failure rate. And then we're designing for companies to go in and lend against this insurance. So now it's going to be the first time we have secured debt in the biotech industry. Essentially, you lend, instead of having VCs taking 25 or 30% of your company to finance your trial, you have a loan lent to execute the trial, the $100 million. If the trial fails, Lloyd's pays back the lender, essentially. So the only thing the company has to do is finance the premium of the insurance, essentially. So we're launching that as we speak, essentially. We're talking to a bunch of lenders, but it's going to be, I think, one way of essentially keeping the cost of development down, given this earning pressure that you're talking about, that's clamping down on the industry.
Any other questions? Please.
China seems to have a low lead time, low regulatory, compared to the US, that is, a drug development system. And what are your thoughts? Will the Chinese rapid speed and relative lack of regulation affect innovation in the US because it's comparatively disadvantaged to innovate here versus China?
So FDA has long been viewed as, quote unquote, the gold standard, which is not a good thing. They're over-regulated. What other market do you have 10 years from idea to market? Imagine we have software that took 10 years from idea to market. It's a very long process because you only are concerned with bad drugs going on the market as opposed to good drugs being prevented coming on the market because of all this regulatory delays and also the cost of waiting 10 years, essentially. So FDA is more stringent, which is a bad thing in my view, than many other countries. Now, Chinese production used to be very prominent for generic drugs. But since the Trump administration started with their tariffs, et cetera, that's moved out of China a lot. Now India is sort of the center for generic drugs. There's still a lot in China, but it's not as much as it used to be, essentially. They're not so big in innovation or brand name drug. That's a general phenomenon that US is very innovative relative to other countries. But the whole world innovates for the US. US provides about 73% of total global earnings for pharmaceuticals, even though we're about 23% of world GDP, essentially. And the reason is because we don't have price controls, and other countries do, essentially. So if you innovate, if you're a Swedish company, you don't innovate for 10 million Swedes, okay? You innovate for the world. And the world returns come from the US. US is basically the global provider of the returns to medical innovation. And that's why there's this discussion about when you have all these price controls in Europe, this free riding going on, that they basically let us have the high prices to support innovation, and then they get their drugs regardless of what they're doing with their prices. It's very rational for those countries to do that. So if you're Belgium, whatever you do to your reimbursement for drugs in Belgium does not affect innovation, because innovation is driven by the global return. And you can shut down Belgium for all I know, and nothing happens to medical innovation, okay? So there's no access, innovation trade-off in these small countries. Whatever prices they set, they see the same flow of new drugs coming into the country, no matter what they do. So why try to have a high price to quote unquote support innovation? Doesn't matter. Unilaterally, they don't affect innovation at all, essentially. So it's very rational why those guys are holding down prices. If US did what UK did at NICE, that would be a massive impact on world innovation. Like I said, we're currently 73% of earnings comes from the US. If we have price controls in the US, which they do in the UK, talk about it drying up private equity. It would be no private equity because innovation would be gone if we did what they did. So that would hurt a US citizen, even though UK price controls don't hurt the UK citizen. If we had US price controls, it would hurt the US citizen.
Possible mechanisms. Prices. I mean, they're the mechanism for balancing.
Yeah, that's why I favor the trade agreement approach to this problem. I think that's the only way to get it. You're never going to get Canada to go to US prices by just asking them, right? That's got to be a stick if they don't. I mean, it's the same NATO problem where, defense is the ultimate public good, but global returns to innovation is also a public good. You want the other countries to provide it. You want to have cheap drugs in your country and then have expensive drugs in the US so that people still innovate. But then you get all this cheap stuff into your country that is not affected by what you're doing, essentially. So I think there has to be kind of a trade agreement approach to stop that free riding in some sense, just as we clamp down on US having more NATO spending than other countries in percentage terms. I think we should clamp down on that kind of activity by those countries as well.
Any other questions? I have a couple to end it, actually. You talked quite a bit about Inflation Reduction Act and everything else, by the way. And one of the things that you talked about is that the pill penalty, that is supposedly the executive orders told Congress they need to fix it, which it needs congressional action and it's legislation. It's not like you can do it through executive order. What other things can we do to sort of right the ship from what IRA is doing besides the pill penalty? Maybe.
Well, I think the price negotiation is, I don't think it's going to want to have a big impact. And so you saw in the previous, which was very interesting, the co-pays have actually risen, which was, I thought was very, very interesting. But I think getting rid of, I can't imagine that this is going to do good to us in the long run, essentially. So there's always with patents, there's always a dynamic and static trade-off. Basically, if you want cheaper drugs today, we could just disallow patents, right? That would be a great way to lower drug prices, right? But that would not be the optimal strategy in the long run. We would have zero new drugs, okay? So there's always a trade-off between clamping down on prices, whether it's price controls or what have you, today, which benefits the current users of the current technology, but it doesn't benefit the future patient populations who's going to live off innovation or better technologies in the future. So we want to be careful. Innovation is always expensive in the beginning. So look at the cell phones of the 1980s, these clunks that only people in Rolls Royces were having in their car, essentially. Very expensive. Today, you have every person in developing countries have a cell phone, essentially. So you always have with innovation that it starts high and then comes down, essentially. There's nothing unique about that. That's not only patents, it's also that learning by doing over time to make things cheaper. But you can't take the myopic view that, look, if we have price controls on cell phones in the 80s, imagine what would happen. It would be drying up cell phone innovation. And we wouldn't have all the stuff we have today, essentially. That was very expensive. We could have said, why should only rich people have mobile phones? We should, make it more equitable, blah, blah, blah. And that would hurt us in the long run. It's exactly the same way with any type of innovation. Patents are bad in the short run, but we reward something good with a monopoly, which is bad. And that's the problem with patents. But we haven't figured out any other way to do it better than rewarding something good with a monopoly that's bad, essentially. And that therein lies the problem, I think.
Any other questions? I have one more to ask you. I want you to talk a little bit about competition, because one of the things that I always say is that competition doesn't start for medicines when it goes generic. It actually starts within the next drug that's introduced into the marketplace. And why don't we see that? And what is the best way to observe that as a society? Because we know when you're in the industry that competition drives down the net prices of your drugs. But we don't see that externally because the wholesale acquisition cost prices keep going up. But I want to hear your opinions of how we can convey that message to the society.
Well, it actually is a lot. I mean, people have studied this, and this is what's called therapeutic competition. This is competitions between two patent holders. So this would be, Prozac versus Zoloft in terms of antidepressants or what have you. It's basically patent-to-patent competition, as opposed to when patents run out, when you get generic competition after patent expiration. That is actually a huge impact on lowering the total rate of return on investment. So if you look at what would a drug earned if there was no competitor in that drug class, other brands, and it's about 50% roughly of the earnings gets destroyed before the patent expires, okay, from therapeutic competition, from brand to brand competition, essentially. So if you look at hepatitis C, for example, Sovaldi was like, the first drug we heard about, which was almost a cure. It's gotten even better. But it was the first drug that had a big prevalence, or a substantial amount of prevalence of number of people who have the disease, hepatitis C. And at the same time, it had a really high price. So the spending was high volume, high price. A lot of other drugs had much higher prices at the time, but it was for tiny diseases. So the insurance companies barely noticed it because it was such small populations that they were paying high prices for. Sovaldi, everyone was screaming when Sovaldi came out that this is outrageous, blah, blah, blah. But if you look at how therapeutic competition, how quick it came in that class, it was remarkable. Prices got cut by 50% after a year or so, when Merck and I think AbbVie was the ones who were in that class came in. So that's an example of where the patent's still running, but you're losing a ton of revenue compared to if you would be a monopoly for the whole patent because of other brand competition coming in. So there is a substantial amount of therapeutic competition, which does destroy innovative returns, but it's patent-to-patent competition.
Any final questions that you may have? Everything's clear about the IRA. We're gonna fix it. We're gonna fix it. Your whole I have to give because I remember when you brought up in the National Economic Council the whole trade deal to increase prices in the developed countries, and that turned into international price index. Somehow it got hijacked by that whole idea, and it seems like it's going to rear its ugly head again.
Probably, yeah. Probably.
And that's to index prices of US to the international markets, while the idea of doing it through trade was the rational way. We're going to an irrational direction now again. So thank you so much. Jim, I'm going to turn it over to you.
Good evening. I'm Colby Hewitt IV, grandson of Colby Hewitt Jr., and it's my honor to close tonight's event. Thank you, everyone attending. Tonight isn't possible without people willing to commit their time to intellectual curiosity. Thank you, Wilmer Hale, for hosting. And thank you, Dr. Bill Smith, Dr. Robert Popovian, and Dr. Tomas Philipson for your insight on the Inflation Reduction Act, the concept that global returns to innovation are a public good, the ability of successful drugs to make a profit has to be maintained and protected. In 2006, Pioneer Institute launched an effort to endow a healthcare research and lecture program in memory of its former chairman. My grandfather would have been honored and humbled to know the incredible lineup of talent that has blessed Pioneer through their participation in this event. But given his strong belief in the mission of Pioneer, he wouldn't have been surprised. The Hewitt family's political inclinations are diverse, and my grandfather took great pleasure in family debate. But we all hold in common a great respect for intelligence, facts, and above all, discourse. The Pioneer Institute does the legacy of Colby Hewitt Jr. proud with the work that they do tonight and always. Now more than ever, it's critical that Pioneer continue to be a major part of the public narrative, informing transparency, data-driven decisions, and better outcomes. Thank you all for your participation in tonight's event.